Um, Good morning, dear colleagues.
Good
Good morning.
Good morning.
So,
Good morning.
right now we are going to have a session on family planning, and this is for the assignment we are having in postgraduate certificate for teaching and learning in high education. So, right now I'm going to share my screen. Well, we are going to have a small session on family planning. Okay, can you see the screen?
Sure.
All right. So we are going to have a small discussion on family planning, and this session will not take as longer than 30 minutes. I'm inviting you to follow, to ask questions, and if there is any addition or something else you need to comment on, please feel free to share your opinions or your advices. Can one of them be switched off? Thank you. So the learning objectives for this session is to define the contraception, family planning and contraception itself, and describe the potential benefits of contraception, different contraceptive methods, the perfect use versus the common use. That's where we are going to discuss about advantages, contraindications, mechanism of action of each contraceptive method. Then we are going to see how we should be doing the counseling for patients and the couples of family planning, and the useful apps for decision making on contraception. You know, this era we are using a lot of technology, and right now we are having WHO app that can help a healthcare provider to select a person's eligibility on family planning. So, on definition, family planning is defined as the ability of individual and the couple to anticipate and attain the desired number of children and also the spacing, timing of their birth. Here we are going to insist on the individual and couples, because most of the time we think that family planning is just made for people who are married, but also we have seen as healthcare providers that we are having so many single people that are coming also for spacing or timing their birth. So it is achieved through the use of contraceptive methods. And here we are going to insist on both natural and modern methods. So any reproductive aged person, male or female, regardless of marital status, is eligible for family planning services, including information, education, and counseling. So not only we give the methods, the contraceptive methods, but also somebody can come for family planning to get information related to that, or also to get education or the counseling itself without even using the method. So this is the WHO fact, where we can see 214 million reproductive aged women do not have access to reliable contraception. And this is one of the huge problems, because the majority of almost 90% of these reproductive aged women are located in low-income countries, which are Asian part and also sub-Saharan part. So some family planning methods, such as condom, prevent transmission of sexual transmitted disease like HIV and others. But also family planning reduces the need for abortion, especially unsafe abortion. And if we take a look a little bit on the rights of reproductive health rights, we see that the family planning reinforces people's right to have the desired and number of children, and also the spacing, depending on how they want to get their children's spacing. By preventing unintended pregnancy, family planning also prevents deaths of women and children. We have seen that most of women are having unintended pregnancy and end up having the contraception, the lack of contraception, but also end up having unsafe abortion and die for the complications. So women who have more than 4 children has increased maternal mortality because of other obstetrical complications that are related to that. So, but also it helps to reduce adolescent pregnancy, often complicated by preterm and low birth weight babies. This brings the neonatal mortality at a high rates, and also often adolescent girls are leaving school when they are getting pregnant, which increases a lot of socioeconomic problems. So, what about Africa? What about Asia and Latin America? These are the areas where I told you that most of the 214 million reproductive aged women are located. So in Africa, 24.2% of women have unmet needs of modern contraception. In Asia, it's 10.2%. In Latin America and Caribbean, it's 10%. So you can see that this is a really high percentage where women are having issues of not accessing reproductive health rights in family planning. So what are the reasons for these 214 million women not having access to family planning? So there is a limited choice of methods. I think so far, like in East Africa, family planning is free. But when you go to other countries in Africa, when somebody needs like an IUD and or an injection, sometimes they pay. So they don't have choice because most of the time they don't have money to pay for that. So there is also a limited access to contraception, especially young people and poor or unmarried people. There is this discrimination that young people should not have contraception if the person is not married, but also for the vulnerable population, including the poor people, the people with disabilities, that they have limited access. So there is also fear or experience of the side effects, culture or religious opposition. You know, here in Rwanda, most of the faith-based health settings, they don't offer family planning. So there is also poor quality of available services, where you find that the services are not well provided. But also the users and providers bias when there's judgment, or they don't think like somebody should not get, especially the young people or the unmarried people. So there is also gender-based barriers. Well, men, like married couples, well, the man thinks that the woman should not get family planning for certain reasons. So before we move on, can you please tell me the benefits of family planning? Hello?
Hello.
Yes.
Hello. Yes, thank you for the presentation. And so far, I can see that there are benefits of family planning. for families or for at individual level, but also at the family level and at the country level. Because if a family is applying family planning, they can have the children, they can afford to educate, to pay education fee, to raise in the limit of their income and financial and economic means. For the country also, it goes in the same. If we have family well sustained, we will also have a well-developed country where we have children who are educated, who can afford school, who can also contribute to the development of the country. Yeah, that's what I can say. I think others can also find some other. Of course, if we look at how a woman who is giving birth, if you are giving birth to, let's say, 5, 6 kids, we know how it takes energy to be pregnant for 9 months, and the time of breastfeeding, all the necessary time it takes, energy. So women who have limited pregnancies, they stay healthy and strong. They can also contribute to the development of the country by going to work, by not getting quite sick easily. So they are healthy and they can be productive at all levels.
Thank you so much.
That's what I can say.
Any other input?
Thank you. Yeah, almost Bertida said almost, but also there is the decrease of maternal mortality rate.
Thank you.
Most of the time, if the mother continues to deliver like every year, she's at risk of those diseases and even the hemorrhage. That also is one of the big causes of maternal mortality. Also, if she's the family planning will help her to have spacing, and she will have like a number. She will get pregnant when she wants. She will have time to work for her family and even for the country. And also she will be like she's not at risk for those like hemorrhage after delivery and those eclampsia and preeclampsia. Thank you.
Thank you so much. Let's take a look very quickly of what you have said, and I'll make some addition. Like Berthoud just said, it improves the woman's autonomy and economic independence. It helps also women to pursue their education for better employment opportunities and earning potential. And this contributes in an economical growth of their families and also the country. There's also a better utilization of the household income per individual, regulate population growth and its impact at national, regional, and global level. Then adding some other benefits like Adeline just said on reduction of maternal mortality and neonatal mortality rate, but also obstetrical complications on different things. So now we have classification of family planning. There is natural family planning and also modern family planning, where we have barriers, hormonal and non-hormonal, long-acting contraceptions, but also permanent sterilization, women and for men. So this is a table that is showing the different modern contraceptive. So it goes, if you take a look here, on the most effective to the least effective when you go up from here. So this is the least effective, includes some of the natural family planning, like fertility awareness-based method. It is at 24%, the spermicides at 28%, and male condom 18%, 21% for female condom. Withdrawal is 22%. But when you go up, you are going to see the reversibility of the implant, intrauterine device, and you see how the percentage is really like this is effectiveness. When you go, the more you go up, the more the contraception is being effective. So on the natural,
Yvonne, can I ask a question?
Yes, please.
On the same slide. So what do the percentages mean? Because I see that like 24 is greater than 0.05.
The more the percentage is high, the less effective is the method.
So what's the interpretation?
The interpretation is like let me see, like when they are calculating the effectiveness, of the method is being calculated when you see on 100% of women, how many women are getting pregnant using that that contraception. So the 24% of women are getting pregnant when they are using fertility awareness-based method. However, 6% of them may get pregnant when they are using injectable method. Yeah.
Thank you.
Okay, thank you.
Okay, sorry, can I comment also?
Yes, please.
Hello?
Yes.
I can see thank you for sharing this effectiveness, but
Yes.
my concern is about the male condom or female condom, something like that.
Yeah.
A barrier like this, I can see 18%.
Yeah.
I think this is too low. This is too low. How can we say that male condom is effective only at 18%?
You misunderstood what I've said. The higher the percentage is, the lower effectiveness is. Now we'll go, if I can use the Kinyarwanda. Iyo ku 18% by'abantu bakoresheje condom can get pregnant.
Okay.
Yeah. So
actually, in another way, it's effective at 82%.
Exactly. Right? Yes.
Yeah.
So, but also for the male condom, even the female condom, they always add if well used, because some people don't know how to use it. So let's take a look on natural family planning. This is the method that is used as the body natural physiological changes and the symptoms to identify the fertile and infertile phases of the menstruation cycle. So the type of natural family planning, we have periodic abstinence method. Most women ovulate 14 days before their menses, and eggs is viable for approximately 24, actually it's 24 to 72 hours. It's 3 days. So the sperms are available for 5 days. Therefore, a woman can get pregnant up to 5th day before she ovulates and up to 2 days after ovulation. Therefore, one should avoid intercourse for 7 days starting from the 5th day prior to ovulation. That's like for somebody who is having a 28-day cycle, they may ovulate on 14, then 21-day cycle ovulate on day 7, 30-day cycle will ovulate on 16. This requires somebody to be having a regular menstruation cycle, but also to know how to calculate. Because if most of the people will just say they are going to ovulate on the 14th day because they are considering their cycle is being 28-day cycle. So, but there is also coit interruptus, withdrawal or pulling out method. So for the modern, we have short acting, but also we have long acting, reversible one and long acting, which is permanent. For the short acting, we have condoms, male and female, diaphragm, cervical cap, spermicide, and we have oral contraceptive pills. We have two types. We have the POPs and the COCs. So progesterone-only pills, those are the POPs, and also combined oral contraceptives. These are combining estrogen and progesterone hormones. Then we have injectables, lactational amenorrhea. Then we have long-acting reversible, which is having implants. In the implants in Rwanda, we have Jadel and Implano. Implano is for 3 years and Jadel is for 5 years. And intrauterine systems, they are hormonal and non-hormonal. Then permanent family planning methods is bilateral tubal ligation, vasectomy, and also we have another type which is called emergency contraception, which is emergency contraceptive pills that can be used, but also intrauterine contraceptive device. So for the lactational amenorrhea, can someone tell me the condition to use lactational amenorrhea method? Vestine.
Hello.
Yes. Do you know the pillars of using lactational amenorrhea method?
What I know, I think you should respect the time for breastfeeding at least every 3 hours. It means at least 8 times a day.
Mm-hmm. What's another condition? Anyone else?
Another condition is that the child must be less than 6 months.
Thank you.
And the mother should always be with her baby every time where she goes. If she's going to work, she's always with her baby so that she can respect that breastfeeding day and night.
Thank you.
Another issue I should say is that the mother should respect what we call exclusive breastfeeding.
Thank you so much. So there is exclusive breastfeeding, baby being under 6 months, breastfeeding frequently and regularly, which means every 2 hours during the day and every 4 hours during the night. But also the mother should not have the return of the menses. Thank you. So this is what we just said. These are the 3 things that a woman should be observing to say that she's using lactational amenorrhea. These are the conditions. So then we have condoms, barrier methods, male condom. We have most of them are in latex rubber, effective typically used at 85%. Advantages is that the condom protects against the sexually transmitted disease. They are easily accessible, depends on where the person is and who is the person, because it's not also easy accessible like for the young people. Few side effects. Disadvantage, they must be used with each act of intercourse, then requires the cooperation for both partners. Another barrier method, we have spermicides and macrobicides. They are marketed as cream jelly suppository form and formed in aerosol container. So their mechanism of action provides physical barrier as well as chemical spermicide action. They are just killing the sperms. So the active ingredient is nonoxynol 9 or octoxynol 9. So we have also the diaphragm. Diaphragm is like a capsule that you are putting on on the cervical, on the cervix of the woman. So it can just go there. It's like, if you take a look on when you are closing, when you are putting a capsule on a bottle, so it works that way. It just goes on the cervix, and you know when the cervix is not dilated, it's having a little bit of space where you can just put something, and it's a kind of closing it. So if you take a look on how it will be presented. So the diaphragm is effective at 92–96% because it's just closing. It's just closing the cervix. Nothing can go inside. So it has to be fitted, and the woman needs to be taught how to insert it. So it has to be inserted prior to intercourse. It is also recommended to use with spermicide to increase effectiveness. It can be left for 6 hours for intercourse, then remove and clean. So which means the person should be just observe those 6 hours so that they can wash, like do a vaginal douche to clean up all the sperms. Then we have cervical cap, which works at 71%. It also acts as closing. It should also be used with spermicide so that they can kill all the sperms in the vagina. So let's go quickly on oral contraceptive pills, where we have the COCs and POPs. The COCs, they are combined oral contraceptive pills, which has both oestrogen and progesterone. And also we have progesterone-only pills, which are the POPs. They only contain progesterone. And these are only given for women having babies under 6 months. Because if you add estrogen, it will have an impact. Can someone tell me which impacts the COCs can have on a woman who is breastfeeding under 6 months? Somebody? Do you know why we don't give COCs to a woman having a baby under 6 months?
Anything to deal with the breast milk? I'm
Yes.
not sure, but I'm guessing.
Yeah, you're right. Actually, you're right, because it's the estrogen reduces the production of breast milk because it acts on the brain where the prolactin is being released, and it reduces the quantity of the breast milk. Thank you. So they are effective at 99.9% when they are taken correctly at the same time each day. These are the conditions that people forget. If the person is being given the pills, they are supposed to take them at the same time every day. If the person chooses 8 in the morning, they have to continue taking them at 8 in the morning because their action is for 24 hours. And people forget to tell the women who are taking pills that it only acts for 24 hours and they have to respect those hours. And when they say take it in the morning, oh, when do you want to take it? They will say, I will take it in the evening. Today the woman may sleep at 8, tomorrow she may sleep at 11, which means she's not respecting the time of taking her pills. So these combined ones, they have 2 low doses hormone. High dose is more than 50 micrograms of estrogen. Milk dose is 30 to 35 micrograms of estrogen. Low dose is 50 micrograms of estrogen. And actually, when we are going to give contraceptive, we should think of doing hormonal dosage, because sometimes people get pregnant on the pills not because they did not take them well, but just because you give them a lot of maybe estrogen when they needed an increase of progesterone. So in Africa, we just give for giving because we are thinking like, oh, this person is having this, but it doesn't mean that the person cannot get pregnant when she's getting combined oral contraceptive, because she may be having lower estrogen, And when you give her the pills, you increase the level of progesterone and you put it at the normal level, and the person will just be pregnant. So basically, we should really give the contraception, not only even the pills, but other contraceptive. We should be doing it after checking the woman's hormone level. So we have 3 forms of low-dose COCs. We have monophasic, biphasic, triphasic. So for better understanding, later there is in the references a book that is explaining what is monophasic, biphasic, and triphasic. So the mechanism of action, they primarily prevent the ovulation, prevent synthesis of gonadotrophin from the pituitary. It just gives the negative feedback, prevents developing the dominant follicular also for the luteinizing hormone to surge. Hence, ovarian follicle do not mature and ovulation does not occur. The advantages, they help against risk of pregnancy, of course, because there's no ovulation, endometrial and ovarian cancer. And this is a subject of discussion. Most of the time, people don't understand how it prevents endometrial and ovarian cancer. And when you take a look on what is a cancer, it's abnormal multiplication of the cells. So it prevents endometrial cancer because whenever somebody is getting pregnant, there is a stretching of cells of the uterus, including the endometrium. So if the person doesn't get pregnant all the time, that means they are protecting the stretching and losing of the cells, which can cause later an endometrial cancer. But also for the ovarian cancer, because it stops the ovulation, which means there will be no multiplication of cells to constitute the ovum, and the person will be protected. So symptomatic PIDs, the ovarian cyst is also being, the person is being protected of that. Iron deficiency anemia, because some people get anemia through their menses, and most of the time this contraceptive also helps in a little bit stopping the menses. So it reduces dysmenorrhea and ovulation pain. And this dysmenorrhea, actually, we use the COCs for treatment of dysmenorrhea for people who are having really big pain, and make sure that they just have less pain during their menses. Then we have the menstruation bleeding problems, which is being reduced, while the COCs are being not only for contraception, but also for treatment of this dysmenorrhea or menstrual bleeding problems. But also the symptoms of endometriosis, because these people with endometriosis will be having pain, having more menorrhagia and other things. So we use the COCs to treat them. Then there is excess of hair on the face of the body. Well, we give them for the people who are facing this when they are still teenagers, because they have androgens that are increasing. They have male hormones, but when you give them the COCs, it reduces it. But it can also stop the production for the male, so that you can just reduce the teenagers' excess of hair all on the body. The side effects, of course, there are side effects. Whenever you are going to give the women these COCs, you have to tell them about the side effects. So in the beginning, there is a lighter bleeding because it's getting used to the body. It may be also irregular or infrequent bleeding. And there is amenorrhea, which most of women like, but also others have anxiety having amenorrhea, thinking they are pregnant. There's dizziness, headache, nausea, abdominal pain, weight changes, breast tenderness, acne, mood changes, slight increase in blood pressure. All are laced with lower dose of estrogen It's also contraindicated with women with blood clotting disorder and women with migraine who are heavy smokers beyond 35 years, but also the people who are having uncontrolled high blood pressure. For the PRPs, they have low dose of progesterone, and they can be used throughout breastfeeding. They are safe and suitable for nearly all women. All pills are active pills. So mechanism of action is the same: thickening cervical mucus, disrupting the menstruation cycle, which includes the prevention of ovulation, and that women with progesterone and cancer are contraindicated to take that. Side effects, almost the same as the COCs. People may be having headache, dizziness, breast tenderness. It's also contraindicated totally for women with progesterone allergies. So, after the pills, we are going to talk a little bit about injectable birth control, which has progesterone only. The types we have Depo-Provera or medroxyprogesterone acetate. This is the common one for 3 months in Rwanda. We have a norethisterone eternate net-end, which is 200 milligram every 2 months. And now we have another one for 1 month, but I don't know if it's being marketed everywhere, but I know in our best they're having it. So the mechanism of action is the same as the COCs. It inhibits ovulation, thicken the cervical mucus, thin endometrial lining. So advantages: for the one of 3 months, it's effective for 12 weeks actually. Independent of sexual intercourse, safe for use during breastfeeding. Disadvantage: no protection against STD, irregular bleeding, spotting, weight gain, depression in some women, but also vaginal dryness. This is what women report most of the time. So one should be are we supposed to give this injectable? It's actually for all the hormonal methods. We should be giving within the first 7 days following, the 5th day of the menstruation cycle, because now we are going to give that negative feedback for the stopping of the release of LH and the SSH. So immediately within 7 days following abortion or spontaneous one, the inducted one or spontaneous one, then it depends. So you can repeat it every 3 months or every 2 months or every month. So right now, I think in the market, we are having what we call Sayana, which is self-injection. The woman doesn't need really to go to the health setting. So then we have an implant. Implants, they are flexible, matchstick-sized rods made of soft plastics. And as I told you from the beginning, we have 2 types. We have Jadel for 5 years and Sino implant or trust implant, or which is for 4 years, but we also have Implanon for 3 years. So this trust implant and Sino implant, levonorgestrel, they are not common in Rwanda. We only have Jadel and Implanon for the moment. So these 2 rods contain progesterone only, and they are put under the skin of the woman. Mechanism of action actually is the same as other. We have inhibition of ovulation. We have also thickening of cervical mucus. So advantages: one of woman out of 100 using implant over 5 years can get pregnant, but it's not common for sure on the implant. So a good alternative option for women who can't use estrogen-based contraceptive, but also it is a long-acting, really a long-acting contraceptive. Return to fertility is immediately after removal. Oh, I forget to tell you, one of the side effects of the injectable that is being now, like the research have shown that women can take longer to have a return on to fertility. Like if they have used this injectable contraceptive, they can, for 5 years, the return may even be 5 years to fertility. So you have to tell the women. I know most of women prefer to take the injectable one, but for sure, this is something that the researchers have been showing, but also we have seen some cases. So for the advantage of the implants, it helps to prevent ectopic pregnancy, of course, because there's no ovulation. It helps protect against pelvic inflammatory disease, iron deficiency, anemia. Actually, it's almost the same thing as other hormonal methods. Even the side effects, you can see abdominal pain, headache, weight change, breast tenderness, disease. It's the same as other hormonal methods. So if we take a quick look on IUCD, these are intrauterine contraceptive device. We have several types, but in Rwanda, we are having 2 types, the copper-bearing IUCD and hormone-releasing IUCD, progesterone. This can be given immediately right after delivery or 6 weeks after delivery, or also any woman who's not pregnant can have it. So the mechanism of action is presenting the fertilization. So it causes an inflammation-like response when it's being administered to a woman and prevents the sperm motility and reduce their viability. IUCD advantages: highly cost-effective, long-acting, because it can reach up to 12 years, actually. The copper IUCD is 12 years, and the hormonal one is 5 years. Appropriate for lactating mother. This is copper IUD, because even the one with the progesterone only is okay for women who are lactating. So the copper IUD can be used for women who are having issues with hormonal methods, actually. Complications: it can bring infection near time of insertion. Do not press it if a woman is having PIUD. And sometimes women experience the menstrual irregularity, but also somebody who is not really experienced to put it can cause a perforation of uterus. So initiation can be given within 12 days after starting menses. Anytime the woman is stopping to use another method, you can just give immediate postpartum, post-abortion, or for the lactating mother. So these were the hormonal ones. Now let's just take a permanent contraceptive method, a look on that. We have the tubal ligation and vasectomy. It's both for male and female, actually. And tubal ligation, we have it in immediate postpartum, in post-abortion, but also in intervals. It depends on the women. Right now, we no longer need a man's consent. It's just a woman's consent that is being considered when she wants to do the tubal ligation. But there's other conditions. Does someone know another condition that is required for the tubal ligation?
Yeah, like when you are above 35, if I remember well.
Yes. And
you have maybe 4 children. I don't remember well.
It's 3 children, actually.
Okay, thank you.
Yeah, more than 35 having 3 children. That's a condition. Otherwise, they are not doing it. Unless if the person needs it, like you sign the consent, you really want it, there's nothing they can do, they do it for you. So vasectomy also is done for men beyond that age, but also with more than 3 children. So this is how it is done, actually. and they just cut the fallopian tubes, and there will be no longer the move from the ovulation will take place, but it cannot go anywhere. So, lastly, we are going to talk about emergency contraception, which is the contraception that is being taken right after unprotected sexual intercourse. It's given to people, everyone is eligible with, if they don't want to get pregnant, but also after forced intercourse, which is rape, we can always give to women, but also sometimes people may use condom incorrectly and broke or slipped, and the person comes to require for emergency contraception. So it's being given. There are so many types of emergency, but we may use COCs pills. We may also use progesterone only pills. It depends on what is available. But right now we are having so many types. So the mechanism of action is just prevent or delay ovulation. That's it. It's also safe for all women, but to provocate the diseaseness, nausea and vomiting, and breast tenderness, because it's like giving a lot of progesterone at the same time. So you are going to take a look later on this PowerPoint where you are going to see the methods, dose, but also what is being used in this table is giving you. So these are the criteria for eligibility criteria classification categories for WHO. So we have 4 categories. 1, use method in any circumstances. 2, generally use advantage outweighs risk. 3, generally do not use risk outweighs advantages. 4, the method not to be used. So this is the classification, but when you are downloading the WHO eligibility wheel, you see all these conditions. If you're having high blood pressure, if you're having somebody with diabetes, if you're having somebody with blood clots, it gives you a little bit information. So you are going to have a look later on this WHO chart of categories. You can see, like here in the red, somebody with DVT-PE established also anticoagulant therapy. You cannot give COCs at all, but the person is eligible on copper IUCD. So lastly, I wanted to talk about the counseling, how you should be doing the counseling. And the counseling is a type of patient-provider interaction that involves two-way communication. And for this family planning counseling, you really need to talk to the person. You really need to tell them what is going on. You don't have to choose for them. You give them all the information. You allow them to choose for them, which is called informed consent. You let them choose what they want, and you give them information, they give you a consent, and they will choose their method, and later on, you are going to see if they are eligible for that method. You don't have to be judgmental. You don't have to do any other thing. Before you judge the person, you have to remember that you are a healthcare provider. So the principles are very simple. You just cultivate good patient-provider interaction, create atmosphere for privacy, respect, and trust. You cannot just start giving counseling outside where others are just listening. Ensure confidentiality, not just repeating, oh, this woman who came, she just had 6 babies with different men. No, you don't have to be judgmental. You need to get values, behavior, and decisions that differ from your own. You have to accept that the woman may have the value, behavior, and decision that may differ from your own, but you have to behave as healthcare professional. You show the empathy, of course, as healthcare professionals. We know that you have to show empathy. Comfort, you have to demonstrate the comfort addressing sexual and gender issues. Take time during interaction and express interest, provide reliable factual information, but also patient needs to understand. You need also to give this, you know, when people are learning, we learn every day, not only in school. There are those people who learn by touching, who learn by seeing. So if you are talking about family planning, you really need to bring all those methods. You need to show her pictures. You need to show her everything and explain to her how this thing is. I'm saying her, but the cousin can also be, they can also be a couple one. It's not only one person. So the techniques and steps we use already: rapport building, exploration, decision making, and implementation. This is something you can discuss later about the counseling techniques. So, in summary, any reproductive age person, male, female, regardless of the marital status, is eligible for family planning service, including information, education, and counseling. Family planning has health, economic, and social benefits at individual, national, and global level. The implants and IUCD are effective, long-acting reproductive contraception, but also we have the emergency, and you really need to have skills for counseling for the couple or the individual that comes for family planning. These are the references that you can read, and thank you so much. If there is any question, you're welcome to ask. Any questions? Hello?
Hello.
Thank you for the presentation.
Thank you so much.
Thank you for the presentation. The presentation was so interesting, and we gained more information about the family planning.
Thank you. So we are now at the end, and thank you so much for your time and for the questions asked. I think we are ready for the next session, and thank you so much. Have a very nice day.
The same to you.
Same
Thank
to
you so much for the nice presentation.
Thank you.